So thank you for being here last day, in the morning hours. So basically, nothing is, sure in life, and you have to actually, be careful every time. A good judgment is to make the best decision based on known information. But for, good judgment, you have to have some amount of experience, and experience comes with doing things and not by sitting in the couch. So, some basic things. Don't forget to, check out, even after you've done your 1,000 vitrectomy, don't forget to, check out where you are injecting your soccer cannula. So, let's look at this, why this is important. So you have to visualize your cannula inside. As you can see here, you can visualize the cannula. So this is something very important. Do it before you begin your surgery. Otherwise, what happens is, after a time you become complacent and just keep watching this area. So you have subretinal intuition here going in, and you have a suprachoroidal intuition. So you need to stop your intuition, go to a different port and check whether it is inside the vitreous cavity or not. And then what you do is, ideally you can take a 6 mm cannula. So I'm taking a 23 gauge 6 mm cannula here and making a separate port. And again, don't be too sure that you have a 6 mm cannula is going to go inside, but you have to check. So this time you can sort of be sure that you are inside, and then you can start your surgery again. So this is something that Dr. Aniruddha has also shown, and see where my assistant is injecting, and he injected in a jet, and see what happened with the BBG injection. It has gone subretinal. So once you clear up the BBG, you see it is subretinal. So ask your assistant to be gentle, and in these kind of situations, sometimes these can create trouble. Maybe you might do laser, you might not do laser, and of course you need to do gas to sort of tamponade for these macular holes. So this is how it looks at the end. So let's look at this case. So this is a routine macular hole case, but just see here at the end of the surgery we found that this area was lifted up. So we did laser barrage here, and you have to drain the fluid out, and once you have drained and you settle the RD, then you need to do a little bit more laser on this area so that this doesn't progress to a detachment in the post-operative period. So this is something, it's very important to check your periphery and see whether, because of the vitrectomy and the shaving of the ora, etc., you've not created any iatrogenic retinal detachment. So next is this subretinal hemorrhage. This strange, this is basically a retinoschisis related RD. So you have this owl-shaped owl eye looking, like breaks looking like owl eyes. So once I started doing, laser here, I realized if you look at this part, laser was not, taking up. So I realized there's a traction here, and so I started doing a, limited retinotomy. So as you can see, the cautery is holding up the retina, and therein, you start, you have a subretinal bleed here. So the subretinal bleed can be managed. It can be, you can take out the subretinal bleed with a flute needle, and once you take it out, you need to laser up the area, and you can, be sure that this is not going to create trouble subsequently. Now let's look at fish egg formation. So when you inject PFCL, you can have fish eggs. Just soak the fish eggs; they will go away. And ask your assistant to again, you see lots of fish eggs, and you can just inject within the PFCL bubble and just movement with your and you can have the fish eggs going away. So another important thing is, when you are in fluid air exchange, don't restart the infusion at a very high flow rate. Otherwise, you can have jet stream breaks here in this part. So what you basically do is you reduce the infusion to maybe around 15 or so, and then you gradually fill up the vitreous cavity, so that you can avoid this is very important. Now, nowadays we don't have too many FAK cardies, but just to show how to manage, a silicon-filled FAK cardi, the AC part of it. So once you have, filled up with silicone oil, so you can, what I'm doing here is injecting some pilocarpine so that the, iris, the pupil becomes constricted. And after that, it's important to inferior PI. It's very important. Otherwise, you'll have, tremendous rise of pressure post-operatively. The whole purpose of the surgery will be lost. So, that you can see I'm doing an inferior PI. And once you've done this inferior PI, what you can do is you can go in with a 3 mm, syringe. You can, inject some fluid, and you can cross-check your how the pressure is, and then it's a good idea to close this. I usually close my silicone oil filled eyes. So thank you, and that was the last video. So and we are open to a little bit of discussion. I think we have maybe just a minute's time.
Yeah, you have already shown that very important point, the inferior PI. That often you have to do some kind of gentle cautery, otherwise postoperatively you may face.
Yes, some of them do bleed, and so in such situations,
Yes.
the postoperative cautery is in order.
Doing cautery into the PI, it's like double-edged sword. If you are doing cautery, it will be closed, and if you are not doing it, it can end up with high fever.
Yes, yes, and actually,
sometimes it closes. It's
yes,
not always closed.
And in fact, if you do a cautery, what sometimes we've seen is it enlarges a little bit because
Yes.
there is constriction, all around, and it enlarges a little bit and keeps the PI open in the post-operative period also. There'll be, it'll not close up. Yes, Dr. Rupak has a point to make.
There we get RDs, they present very early. We tend to operate them within 1 to 2 weeks. We emphasize more on using gas rather than oil. And in case of PVR cases, I think everything is covered today. Only one thing is buckle, which is 276 buckle, which I think is very helpful. And do retinectomy, which is last option, but in a stage manner. First you put oil, leave it, see the patient again in 4 to 6 weeks, and then you do retinectomy. The idea behind this is that it's mainly because of the RP which is causing it. So once the jelly is out, the RP is out, the inflammation is out, and then you will not get a recurrent PVR. Otherwise you cannot study detachment or doing recurrent PVR. And to trainees, I'll only say, always see the patient before surgery and make a plan, stick to that plan. You don't need to be a very efficient surgeon, but the decision making is very important in your surgeries, and you will avoid all the complications because of that. Thank you.
Yes, I think, very important points, and it's very important not to, be scared once you have some iatrogenic complications, because you'll have complications as you go along and operate, cases. So, but, to move on after the complication is very important. So, any further comments, questions? So I think we'll hand over the dais for the next, presenters. And can we have a photograph? Yeah. Would like to invite Dr. Priyam, Dr. Ashmita, Dr. Rupak